Good afternoon. Welcome to Ask the Mito Doc, and thanks for everybody who's tuning in virtually, and thanks to everybody who is here in person. So I am Amy Goldstein. I'm from the Children's Hospital of Philadelphia, and I'm really excited to have everybody who's here on the panel joining me. So to my left is Dr. Jennifer Yang, who is from UC San Diego Rady Children's Hospital, and then is Dr. Bruce Cohen from Akron Children's Hospital, Dr. Peter McGuire, who's here from the NIH Genome Research, then Dr. Austin Larson, who's here from University of Colorado, and then Dr. Missy Walker, who's here from Mass General in Boston. And so we are here to help answer all of your questions. And so what we're going to do, since this is a joint live session plus virtual, is that we're going to try to alternate. And so we're going to take questions from you all here in the audience, as well as answer questions that are coming in virtually. We're also joined by Dr. Elsharkawi, who is from Mount Sinai, and he's joining virtually as well. So again, welcome. As I said, we're here to help answer any of the questions that you have, and we're just going to, again, go for it. Any question that you have, just raise your hand. We have a couple of people here that will be helping run around with the microphone. So if you have a question, please just raise your hand, and we will have Mr. Howard Corson, who's in the back of the room, come with the microphone. And please wait for the microphone just so that everybody has a chance to hear you. So does anybody have a question that wants to get started? We have a question right down here.
Hi, Mike. Hi, my question is, will CRISPR or does CRISPR have any bearing on research, or will it? And do you think it will be used in the future?
That's a great question. So I'm going to let Dr. Yang start us off. And if you can, did you hear the question, and can you repeat the question?
Hello? So the question was the use of CRISPR in the future. I can definitely see a role of using that in mitochondrial disorders. But I mean, right now, I think that's still under development in a basic lab, right now. And, it's nice for single gene disorders where you can have a specific target using CRISPR technology. And, if there could be a platform for which you could add in different genes for a similar technology, then you'd be able to expand and help a more heterogeneous group of disorders. So yeah, it's still in, I think, early development phase, unless someone else wants to add.
So I'm going to add a little bit to that. There are other gene editing technologies, zinc finger nucleases, something called TALEN. This morning we heard about a technology called ARCUS. There's mRNA therapies. So there's a lot of gene therapies coming down the road. This year there were several gene therapies released for non-mitochondrial diseases like Duchenne's muscular dystrophy and spinal muscular atrophy. So if you asked me that question 5 years ago, I would have said it's going to be at least 20 or 30 years, but we're here now. So it's probably going to be for mitochondrial patients far sooner than that.
So CRISPR is something very specific. At its present form, it could require getting specific parts molecular shaping mitochondria, which, depending on what will be from various sessions and which data you get the highest, may or may not be possible mitochondria at this point. But I actually remain hopeful, and I'll tell you why. This year, CRISPR was approved for use for 2 different genetic conditions, thalassemia and sickle cell disease. Those, of course, are mitochondrial disorders, and they're not actually the same gene. And what enabled that was a lot of basic science research that actually found a workaround, a separate activity in the cell that could be targeted without actually changing those genes at all in order to help these patients live better lives. And I remember that with the appropriate investment in basic science and foundational research, that needs to be brought to bear on my cognitive research.
Maybe I'll add a little bit more flavor or detail here. So the CRISPR is in a category of molecules called nucleases. And so the nucleases target a specific place in the genome and create a gap. So they're complementary to gene therapy. So if you have a gene that needs to be expressed in a particular part of the body, you can make a gap in the genome, in a gene that you know is expressed in the place where you want that gene therapy to be active. And you can land the new gene in the right place so that it will actually be functional in the part of the body where it needs to be functional. So it's complementary to some of the things you maybe have been hearing about in terms of gene therapy.
Okay, great. Thank you. We do have an online question. What advances are there in treating single large-scale deletions, especially Kearns-Sayre syndrome? Dr. Cohen, we'll start with you if you don't mind.
Well, I think that there's clinical trials going on looking at targeting disorders like Kearns-Sayre therapy. In terms of gene therapies, I think we're still going to have to wait for some effective treatments to come into the clinic. I'm blocking on any other specific curative or disease-ending therapies for Kearns-Sayre, so I'm going to turn it over to the other panelist.
So I would say there's a couple things going on. There were some sessions this morning that are better defining the natural history of Kearns-Sayre and single large-scale deletion related disorders. So that's really important in the here and now for the doctors to be able to order the right screening test, to know what complications to look for, to know which other specialists to involve. But it's also really important for knowing what the right outcomes are for clinical trials so that we have successful clinical trials that can identify benefit or one truly exists for patients. So for both of those reasons, I think it's really happy to see some much more robust and larger natural history studies with data coming out today.
Okay, thank you. Can everybody hear us okay? Are the microphones sounding all right? Okay, thank you. We had someone online saying that the sound quality was coming out a little bit funny. So I just wanted to let our sound people in the back know about that too. Okay. Do we have another question from the room? Anyone here have a question? Again, please put your hand up and the microphone will come to you. Thank you.
Thank you for being here. The hope of the future for genetically confirmed diseases seems to be gene therapy, but what's the hope of the future for mitochondrial diseases that aren't genetically confirmed?
Okay, Dr. McGuire, would you like to start answering? Oh, that's fine. Dr. Larson?
Sure. So I think there's two answers to that question. So one is there are patients who have very, very specific manifestations, and we look for the genetic cause of them. We know that it has to be there because of maybe a particular metabolite that's very abnormal or a very characteristic combination of physical features. So one answer to your question is that we are getting better and better at diagnostic techniques. And there's some posters here today about using what's called multi-omics. So if you just do our standard best first line test, which now most of us would consider to be whole genome sequencing, for a lot of conditions, the likelihood of finding a genetic diagnosis when we know that it truly has to be there is maybe 70 to 90% with whole genome sequencing. So there's still a gap, and that depends on the gene. So there's still a gap there, and we're filling in that gap with additional technologies like RNA sequencing, proteomics, metabolomics, other studies that can help us to keep moving that number higher and higher when we know that the diagnosis is truly there. The other part of one of the other answers to your question, though, is that there are some symptomatic patients where the reason for the symptoms is multifactorial. Even if we apply every single test that we have, we're still not going to find a single gene that in and of itself is causative of all of the symptoms. Over time, we may be able to unpack some relationships between, say, specific infections and genetic susceptibilities, or environmental exposures and genetic susceptibilities, things like that, where there's 2 or 3 or 4 causes that together are the mechanism of the symptoms. But that's pretty challenging. You have to have really large scale studies to be able to kind of figure out those complex mechanisms.
Let's say that what we really need is kind of the holy grail for mitochondrial disorders, which is a reliable biomarker of mitochondrial dysfunction. And what do I mean by that? If your doctor is worried that you have diabetes, there is a simple blood test your doctor can do to see if you have diabetes. Not why you have diabetes, but just that you have diabetes. And then he or she can prescribe you a medicine. Check that test again later to see if the medicine made the diabetes better or worse. Kind of like an ultrasound of the heart, with medicine, the heart disease is getting better or worse, irrespective of what's causing it. And we simply just don't have a great way of testing mitochondrial function. And my hope would be that we as a research community could develop a reliable test that catches every time there's a problem with the mitochondria and only picks it up when it's coming from the mitochondria. The problem is we in my meeting broader community don't know how to do that yet. It absolutely certain, as Dr. Larson says, but there are going to be people who have mitochondrial dysfunction for reasons that are going to get picked up on whole genome. That might be because they are genetic, or it may be for reasons we don't yet understand. I do think, though, that this era of genetic testing is going to ultimately help us in unexpected ways. I think probably everyone sitting here has had the experience of meeting a patient that they thought the textbook description of a mitochondrial disorder, sending that testing and actually finding something unexpected. So it makes sense, right? That if the mitochondrion is one part of a cell, you could have breakdown in some other part of the cell in the body. It's going to wear on mitochondria. It's like if there's something wrong. I wish I just think about cars, but so imagine something wrong with your engine, and then your car's not running right. So your tires are going to wear down. Right? I think it's intuitive that there's just so much more we have to learn. And if we could just get better tests that really accelerate our ability to understand. And then in the absence of all of that, it's the researchers, scientists, and me talking as a physician, it comes down to identifying our symptoms and what is causing us the most problem in day-to-day life, and doing whatever we can, irrespective of what we think the cause may or may not be, whatever we can do safely, medically or lifestyle-wise to eliminate And just keep going.
If I can just add to that, so I'm someone who actually studies infection in kids with mitochondrial disease, and I take care of the kids as well who come to visit us at the NIH. And so to build upon what's been said, unfortunately, there are a lot of mitochondrial phenotypes that are not brought out until you have some type of stress going on, right? So that can be either with cells that you're testing or even, people. And so just to give you an example, one of the things that we look at and we explore actually has to do with the function of the immune system in patients with mitochondrial disease. And so if you refer them to a general immunologist, they will do a bunch of tests, and in which case they may not see anything because the individual walking through that door is not experiencing, besides the stress of the waiting room, is not really experiencing, right, any kind of major challenge to their bioenergetics, right, to the ability of their mitochondria to be able to provide enough energy. However, we've been able to, so those individuals would then be said by the immunologist, we don't find anything. Your immune system seems to be functioning normally. Those individuals, some individuals, when they actually then develop an infection, if you actually test them during the infection to look at things like immune function and how their mitochondria works and things like that, that's when you can actually find some of those issues and deficiencies. So we've documented patients who drop their white blood cell counts when they get infections. That's the exact opposite of what you want to do when you develop an infection, right? You want to raise your white blood cell count to be able to fight off that infection. So the way I think about mitochondrial disease, because I study infection specifically, is it's kind of individuals with mitochondrial disease, they have this incompatibility with their environment and with environmental stressors. And the stressor that we're concerned about is infection. And I guess my main point is that sometimes without some type of environmental stress, either in cells or individuals, it can be very difficult to identify them as having an issue with mitochondrial function.
Okay, I think we're going to take a very quick break because there are some slides that the UMDF wanted to put up. Margaret, am I advancing those slides from up here or are they being, yes? Okay. All right. So can everybody see yes, you can. Okay. So these again are the speakers that are up here for you today and where we are all from. And a disclosure that the information again for that we're presenting here today is information for you only. And again, that any information that we provide that we would like you to go back and discuss these one-on-one with your individual doctor. So please consult with your physician at home and any specialist before changing any course of your care. Okay, then I'll go back to our original slide. Okay. And then we are going to go back to a question that came in virtually, and then we'll again come back to the room. So the next question that came in online is a very interesting question about any current research about mitochondrial dysfunction in patients with neuromyelitis optica spectrum disorders. This is a very interesting question. We do have a few neurologists on our panel, and I don't know whose turn it is. I think it actually is Dr. Walker's turn. She happens to be a neurologist. Yes.
But I do not know in my head what the latest results are, but it is something that
I can add a little bit. I'm a neuroimmunologist as well. I don't think we know a lot about NMOSD just because it's a really rare disorder. So the studies on secondary mitochondrial dysfunction in autoimmune disorders still mostly is in MS. So we know that there are different phases of MS, which is the most common autoimmune disorder of the central nervous system. There's an early inflammatory phase where we have the relapsing disease, and then the progressive form of MS where there's a lot of disability accumulation. That is the phase where I actually see a lot of phenotypic so just clinical overlap with some of our mitochondrial patients because they develop a neurodegenerative form where they lose ambulation over time, they become more tight in their muscles, become more fatigued and have other types of disabilities. So we've actually done studies on MS, on older MS patients, showing that there's immunosenescence in those patients, meaning that we think their immune cells have been in overdrive and essentially burn out early. And mitochondria is the main powerhouse of the body in all of our cells. So there's definitely some mechanisms of mitochondria overdrive and kind of dysfunction and immunosenescence in a neurodegenerative phase and in various autoimmune disorders. So yes, very interesting.
Okay, we're ready to take another question from the room.
Thank you. I think this area might have some controversy, but I'm going to ask it. Are any of you, do you think there's a prospect for, I don't know what to call it, mitochondrial transplant therapies? And second question, my daughter has MELAS with 78% heteroplasy. Does that mean that 22% are being damaged because they're working too hard? Thank you.
So there are two, so we had two questions there. So for the first question, yes, that is an area of basic science research and also some very early clinical trials. So it's called mitochondrial augmentation. So harvesting healthy mitochondria from available tissues and infusing them into folks that have mitochondrial disorders to see if they can uptake some of those healthy mitochondria into their cells, get better mitochondrial function, and have clinical benefit as a result. Those are in very early stage clinical trials, but it is the area of the inquiry in terms of potential therapies. Your second question was about, and I'll mention there was a very interesting talk earlier today about, and so this will tie together a couple of questions that came up. So there was a question about gene editing. So there was a presentation earlier today about using the gene editing technique, ARCUS, yeah, exactly, to selectively degrade the mitochondrial DNA with a specific mutation, and then have the cells repopulate the mitochondrial DNA from the unmutated copies of the mitochondrial DNA. So then that kind of feeds into your question about the heteroplasmy level. And so the question was, I think, are the healthy mitochondria being damaged by the
by working too hard, because 78% don't work. Yeah, the 10-cylinder car has 2 cylinders.
I think the answer is we don't know that. And the question you're asking is basically, is this disease a disease of a deficiency in something, or is it a disease of intoxication? Is the broken mitochondria producing something that is actually harming mitochondria that aren't affected? And the answer is we don't know. I would say there are biomarker studies in 32 to 43 patients that show they have illness and controls of certain metabolites. But we don't know if it's particular metabolites cause problems or if they're just up because of it. So fortunately, we really don't know. It's actually the first question, I will express the hesitation in some people have about some good studies with the mitochondrial transfer. And so, some basic scientists, they are not convinced that anyone has demonstrated that a cell will take up the mitochondria from another source. Some people express concerns that it could be dangerous to infuse a foreign substance into the body. And I think everyone would say, even if people were encouraged to accept about it, but this isn't proven yet. And I think it's one of the problems. So as Dr. Larson said, it's being approached in concert with the gene space therapies. And it's exciting. My work is planning to come to clinical trials quite soon. I'm sorry to hear about that.
Okay, I think we'll take another question from the room.
Hi, my daughter just turned 13 and I was wondering if you guys knew anything specific about she has a DNM1L mutation and we're really having a really difficult time finding information on that. She's starting growth hormone therapy and I was also curious about what the outlook is for reproduction for children with it, specifically with her gene, if you do know anything specific about it. Thank you.
So I don't know off the top of my head recall that we had reported any particular aspects of fertility. But what I would say broadly, for any moving gene effect, there are fortunately many strategies, opportunities available for reproductive counseling. And actually, all of us, some of our patients, family members of our patients, were affected by a genetic condition. Please seek out pre-conception counseling. So I would
I guess I was just curious, like, is the growth hormone gonna hopefully force her into puberty and then everything will get back on track kind of thing? Or I just was curious, and plus the DNM1L diagnosis, we can't really find our doctor. We have an amazing doctor, but it's very rare. So I didn't know if anyone had anything.
If you're, and one thing we all, I know we're very happy to do is talk to other physicians. So if your physician wants to reach out to any of us here on the panel, we would be successful.
Okay, I'm going to go to one of the questions that is coming in online. And we actually have, there's a question that came up that I wanted to address because I wanted to see what Dr. McGuire had to say about this one, because I'm curious about the answer. There's a question that came in about how can we help maintain and boost our immune system? And I get that question a lot, and I wanted to see if he had any advice.
So thank you. That's actually a great question. It's a question we do receive, fairly often from our patients and our families who contact us. So the immune system, of course, has many different aspects to it, which is important for maintaining health. One of which actually has to do with diet, right? So there are many nutrients that we get from our diet, which help support immune health, which can be certain amino acids, certain types of fats, any type of nutrient you can think of. You can probably pinpoint somewhere in the immune system where that nutrient is actually kind of important and actually necessary. So good health is one thing. Exercise, to the degree of which an individual can exercise, right, also can be very important for immune health. It can help not only with things like muscle strength and balance and things like that, but also it can help bone and bone marrow in terms of its function. One of the main things that we do talk about with our patients, which is a pretty readily, something that's readily available to all of us, is actually vaccination. So I knew it was going to come up sooner or later, so I will address it now. So there are some concerns in the mitochondrial disease community with regards to vaccination. So especially that was amplified with the COVID-19 pandemic and the introduction of the COVID-19 vaccination. So what I can say at this point is, first of all, their concern about being vaccinated is that an individual will have some type of very strong immune response and their mitochondrial disease will get worse. So what I can say to that, first of all, is that the type of immune reaction you actually get from a vaccine is very different than the type of immune reaction you get from an actual virus or bacteria or something like that. It is less robust in terms of its systemic kind of response that you get. So the threshold there of immune activation is lower than you would get for instance, if you had the flu or something like that. Is there any evidence out there? Well, the only evidence that we have with regards to vaccination in individuals with mitochondrial disease comes from a study that was published probably close to 10 years ago now, where they looked at medical records from the Kaiser group in California, which is like a large, medical group. And they looked at all different types of inborn errors of metabolism. So it's not mitochondrial specific, but they were diseases or inborn errors of metabolism, which there was a particular concern with infection. So in other words, these children normally did not do well when they got an infection. Their disease progressed, it got worse, it could be life-threatening. So when they looked at that specific population, there did not seem to be an increased number of adverse outcomes with regards to vaccination. The last thing I'll speak about with regards to vaccination is one of the things that we do is we do periodically in our patients check to see whether they are maintaining their vaccinations. So in other words, when you're vaccinated for something, your immune system makes protective antibodies, and these antibodies float around in your blood. They have many different functions, but one of which is to actually bind things like bacteria and viruses and help you actually clear them. Some of our findings have demonstrated that in certain patients with mitochondrial disease, their response to vaccinations does not last as long as individuals who do not have mitochondrial disease. So I can't say that with 100% across the board, but there are certainly patients. And it is something that we do screen for routinely. We do revaccinate individuals who are actually have absent titers. So to give you an idea of some of the vaccinations that may be not, or the titers that may be lower or not positive in individuals with mitochondrial disease, we published a study a couple of years ago which showed varicella, which is chickenpox, right? Chickenpox, you're supposed to have immunity for about 40 to 50 years. That's why we have to get the shingles vaccine later on. One of the other ones which showed a reduction in our population was actually measles. And that's particularly concerning because of the resurgence of non-adherence amongst individuals who don't have mitochondrial disease to the vaccination schedule. So vaccination rates have dropped. And unfortunately, there's been a resurgence of measles. The half-life of measles, actually, so this is a calculated value, so it might shock you. The half-life of measles is 3,500 years, right? So it's a really, really effective vaccine in terms of maintaining your titers. In other words, your protective levels of antibodies. And that was another one in certain children with mitochondrial disease that they were not able to maintain those levels. So if I were to pick one, I mentioned nutrition, I mentioned exercise. If I were to pick one thing, it's vaccination, actually, because we don't have any data to say essentially that it is a risk for patients with mitochondrial disease. And we think the benefits, especially with things like COVID and the oncoming flu season in the fall, that the benefits are actually pretty significant there.
Okay, thank you. All right, we'll take another question from the room.
Hello, thank you. So I have LHON and I was also diagnosed with growth hormone deficiency before I knew about my LHON. So is there any way those are related? And I also have heard that people report sleep issues relating to like LHON. So how could growth hormone deficiency relate to that, and how is sleep affected? I also have the mutation 3460, in case that helps.
Okay, thanks for your questions. I'm going to let Dr. Cohen take these because I heard about the sleep question, and I think I've been hearing you talk about sleep disorders and Mito for a long time.
So, Amy, can I ask you to repeat the second part of the question because I missed that?
Yes, so he has told us that he has LHON, and he's also, before that, he was diagnosed with growth hormone deficiency, but also he has sleep disorder, his sleep problems.
So I have taken care of several patients with LHON, but most of those patients are cared for, at least in the city of Cleveland and Akron, by neuro-ophthalmologists. Having said that, I don't know of any specific issues regarding growth hormone deficiency and LHON or mitochondrial diseases in general, other than the fact that many of my mitochondrial patients, and when I say many, my guess is probably around 5% have diagnosed growth hormone deficiency. So there must be some connection. I just don't know what it is, and hopefully the other panelists will. The issue of sleep disorders in anyone with a neurologic disease is something that is of utmost importance. And I think, and we don't have literature to support this, but certainly anyone with a myopathy or muscle disturbance or underlying nerve disturbance should have screening sleep testing done as part of the routine. I can't make that same recommendation for LHON just because I don't have the clinical experience. But sleep disturbances are not uncommon in anyone with a neurologic disease, much less a mitochondrial disease. So I'm going to pass the microphone to a colleague who may be able to address the growth hormone deficiency in a more exacting manner.
I am not aware of a clear link between those two, so it may be that those are unrelated. In my experience, I have not seen other LH1 patients with growth hormone deficiency.
I haven't either, but I'm assuming you have had imaging of the brain. There are additional, clinical symptoms that we can see in LHON patients that are beyond the optic neuropathy that are described. So I think if it's a persistent problem and then, growth deficiency as well, along with sleep disturbances, we just want to make sure that there's not other areas of the brain that are affected.
And I'll just add to that, I think that in some mitochondrial disorders, short stature and growth hormone deficiency is very common that we see, especially in something like the single large scale deletion disorders like Kearns-Sayre syndrome. We see a lot of our patients that have short stature. I think in LHON, we don't see it as often. But as Dr. Cohen said, a lot of the patients with LHON don't necessarily see a mito doctor. They may see a neuro-ophthalmologist or an ophthalmologist and don't always come see one of us. I happen to see a lot of LHON patients in Philadelphia. And I will say I've seen a few that have short stature, but it's certainly not everybody. But one thing I've noticed, I think we all have about the LHON community, is that it is very well organized, thanks to Alyssa. And if anybody knows the answer to this question, it's her. So I would ask her if this is something that's known already, if there has been an association through the registry, and if this is something that's already been recognized or not. And it may just be something that, you know, sometimes, and I think this was mentioned already, sometimes people have more than one issue. It's possible to have short stature and have LHON, and they're not linked to each other. Right. So, did we address both of the questions that you had? Sorry, Howard, could you give him back the microphone?
I was wondering also how LH1 affected sleep. Like, could you go more into detail about that?
Yes, so the sleep issues, and I think I think Dr. Cohen talked about this, but I'll just again kind of reiterate this issue. One of the common themes that a lot of our mito patients have, and I have seen this also in LHON, but maybe not as often, is fatigue is a common theme for our patients, right? We all see patients with mito that come in reporting fatigue. And whenever people have fatigue, and there are a lot of questions online that are coming in about fatigue, we all ask our patients, how are they sleeping? And if they don't feel that their sleep is restorative, we recommend to go and have their sleep looked into, right? Whether it's with a sleep medicine clinic or to go get a sleep study. Because if your sleep isn't restorative, then that's a big problem and you're going to feel more fatigue. And I think Dr. Cohen recognized that in about 40% of his patients, his adult patients, they had a sleep disturbance that was treatable in some form or fashion with either medication or a piece of equipment that helped them sleep better at night. And if fatigue is one of your biggest problems and that's treatable in some way with fixing your sleep, then that's a great fix. So it's worth exploring, especially if you feel fatigued. And again, if you already know that your sleep is a problem, it's a good thing to go get addressed. It's a symptom. Whether that's again part of the LHON or not, we don't know. It could be separate. Yeah. Okay. I think we're going to get back to one of the other online questions. There's a question that came in specifically about depletion that I want to address because I think this is a really good question. Someone had a muscle biopsy and their content testing came back at 55%, with the cutoff of the test being 50% or less qualifying as depletion. So the question is, you know, what does this mean for her? You know, if the cutoff's 50% and her answer, her test result was 55%, what does this mean? And there are a few other comments about the test result. The electron transport chain testing was normal. The muscle had a little bit of elevated glycogen. The mitochondria appeared edematous. But how do we interpret this? There's a lot of information that she got back on her muscle biopsy. But I think it kind of opens up this area for us to talk about when we put our patients through a muscle biopsy, what kind of information are we getting back? And how do we help our patients understand all of this data that comes back on the biopsy? And do we decide that this is depletion, borderline depletion? What does this mean for her? So why don't we just go down the line and talk about muscle biopsy results?
Yeah, sure. I was actually going to just reply to that. I don't think for me, 50% is not a hard cutoff or anything. I think, you know, any testing that you get either from tissue or genetic testing from blood, you know, buccal swab, you know, everything needs to fit the clinical picture. Right. So I think if there's clearly exercise intolerance, myopathy, or any other symptoms that's consistent with a mitochondrial disease, I'm not going to bank on just the results from the muscle biopsy. You know, the patient comes first. So for me, that's not a hard kind of stoppage as deciding whether or not somebody has a mitochondrial disease. The other thing is for depletion. We still want to consider looking at the nuclear DNA as well to see if there's a problem with you know, mitochondrial DNA replication, the ribosom.
The questions today are clearly the most sophisticated series of questions that I've had in my 25 years of Ask the Mito Doc. So both congratulations to you, and the questions that you're asking are the same questions that we ask of ourselves. So one suggestion would be to do a biomarker that is not perfect, but it's okay, pretty good, and that would be GDF-15. Because if the GDF-15 was quite elevated in this situation, I would be concerned that this is a real phenomena and at least sends you down the right rabbit hole in trying to make a diagnosis. The second point is that our sophistication for doing genetic testing in this situation has gotten pretty good in the last few years. People in the audience may not realize, but 25 years ago, the only test that you could really order for a mitochondrial patient was a panel of 12 different mitochondrial DNA genes, which included 3 Leber's genes, a couple genes for MELAS, and some other scattered genes. That's the only test that you could order. Now we can do the entire genome, and the you know, what the genome is getting larger and larger and more comprehensive as we move on, and can do even testing on RNA sequencing, which is a product of the genome. So I would also go down the route of doing some genetic testing. So I'm going to pass the microphone over.
I'd actually be curious to ask some of my neurology colleagues here, because my understanding is I don't do muscle biopsies. Most of the patients that we see or we enroll in our study already have their diagnoses. But my understanding is, as Dr. Cohen had pointed out, you know, with the advancements in genomic technologies, the use of muscle biopsies has decreased pretty significantly, because it's not a small thing to do. Certainly, you know, the thing that I think people, I'm trained as a biochemical geneticist, so this is, you know, the laboratory diagnosis of various inborn errors of metabolism. So, you know, as was mentioned before by Dr. Walker, is we're still kind of looking for, you know, kind of these other really clear biomarkers. I think her boss published something a couple of years ago, right, with regards to NAD and NADH, et cetera.
That was the 3243 paper I was
That was-
referring
okay.
to that we published in Journal of Clinical Investigation.
Yeah.
21.
So I guess what I would say is, you know, genomic technologies have really taken us much further, that's for sure. And our hope is with, you know, the integration of other genomic technologies, which also Dr. Walker had mentioned, plus hopefully the expansion of at least biomarkers, and hopefully, you know, eventually the hope would be screening. But I know certainly things like genomics have definitely taken more prominence, and things like the muscle biopsy have taken a little bit of a back seat. That's my general impression.
One of the other things that I would mention about interpreting the muscle biopsy is that the normals are from people that have kind of a typical level of activity. So there are secondary changes that can show up, including lower quantities of mitochondrial DNA for people that have secondary kind of disuse of muscles for chronic pain or other reasons like that.
I'll add to what Dr. Larson said, that the context is really important, which is We know there's a couple of very famous studies that mitochondrial and mitochondrial DNA content is going to decrease with age. So 20 years ago, my mitochondria looked a lot better than they do now. But I think what you're coming up against and what the question gets at is the idea of a picture is worth 1,000 words, which means it's going to take about 1,000,000 to describe, right? And when this qualitative data can be at times quite helpful, I personally only get muscle biopsies these days in kind of two circumstances. And this is what I tell my medical students and my residents. And one is if a patient has clinical symptoms that suggest to me that there is an issue with the muscle and that we might find something in the picture, in the pattern of the way the muscle looks that would point us to a diagnosis. Though often, even in those circumstances, I go ahead and go to genetic testing first because it's a lot less painful and actually these days cheaper to get a cheek swab or a blood draw and send genetic testing than it is to open up an OR for 20 grand or something that your insurance will get charged. So theoretically, though, if you don't have a genetic diagnosis already, you might be able to use that picture to come up with a qualitative diagnosis of a myopathy, and not necessarily mitochondrial, but any type of disease affecting the skeletal muscle. And then in particular circumstances where I have a high suspicion for a mitochondrial DNA sequence change that would be less likely to be detected in blood. And there's really only one or two of those. But that said, when somebody's already had a muscle biopsy, you can take these qualitative clues looking at that literal picture. And it's, as Dr. Yang said, it's one piece, if you think of it as a game of Clue, it's one little piece of information we put together to infer to get the whole picture.
Okay, thank you all. Let's take another question from the room.
I have KSS and I live in Houston where I have access to every specialty you can imagine with the Houston Medical Center. But either what can we do to get doctors better educated? Because either they don't want to touch me, or the ones that are willing to see me are like, well, I don't respond the way that somebody else would respond with medications. I just don't respond the same way. So they don't know what to do and just throw things at me that don't work. So I don't respond the same way. So how can we get more outreach to the entire country that are willing to, I guess, be more willing to treat people like me?
Yeah, I think that's a great question. Is there a specific specialty that you're thinking about, or all over?
Has specifically emailed with you
Mhm.
and got in touch with you through Dr. Koenig. And because they don't know with my kidneys, they don't know how to manage it because they don't know how to treat. My kidneys don't respond the same way as somebody else with typical kidney disease. And they throw things at me and they really don't know what to do.
All right, so I feel like this is going to be a continuation from our lunchtime discussion. So many of us are part of the Mitochondrial Medicine Society, and many of us are also part of what we call the Mitochondrial Care Network. And the Mitochondrial Care Network right now is 26 sites in the US where we actually establish criteria for hospitals and clinics that would establish the criteria for a center to be able to take care of children and adults, meaning that not only was there a primary mitochondrial doctor there, but also every specialist that you would need to take care of, again, not only children, but the adults as well. Even if you didn't have them all within the same hospital, there had to be the sister hospital nearby that would be right there to take care of the adults. And And we've also, I think the publication was in 2019 that a lot of us participated in establishing care guidelines for what does it take to take care of somebody with a mitochondrial disease. And one of the conversations we had over lunch today was, is it outdated from 2019? And if it's outdated, how is it outdated? And one of the things that we came up with was perhaps instead of saying globally, we need to have, these consensus data, how do you take care of somebody with mitochondrial disease? Perhaps what we need to start doing is saying, how do you take care of someone with this specific mitochondrial disorder? So we maybe now need to say, how do you take care of somebody with MELAS, or how do you take care of somebody with Kern-Serre syndrome, and to start working on rewriting some of these consensus guidelines. But we all recognized it's not for us. We know how to do this. It's going to be for those other specialists, because we know that especially when you're an adult, that it gets very frustrating. A lot of people live in areas of the country where there may not be a specialist right there, or you're having to drive hundreds of miles to get to a center that has a mitochondrial doctor. And we can write as many letters as we want to for the emergency room. And I worry most of the time they end up in a garbage can in the emergency room. And who's reading them, I'm not sure. So that's one thing, is that as we sit on boards and committees and we're trying our best to write the literature to go to the other physicians to educate them. I think a lot of us are very passionate about that. How do we educate the other doctors? I'm not a cardiologist. I'm not a nephrologist. I know this disease, but I certainly don't know how to manage kidney disease or how to manage heart disease. But I want them to call me so I can inform them, this is what I know can happen in this disorder. But I can't be that person who manages the specific organ problem, right? But I think you're bringing up a really excellent point of how do we continue to educate these other physicians? And I think what's become apparent is they're not necessarily coming to this meeting. We need to go to their meetings. We need to be publishing in their journals. They're not reading our journals. So I think that's how I see what we need to do, but I'd love to hear from my colleagues about, how do they answer your question? How do we help you when you need to go to your doctors, and get this management? So how do we continue to help our patients when, their doctors don't know what to do, or don't listen, or, what else can we do to help them? So again, we'll go down the line.
Well, I think we talked about emergency care guidelines, and I am really scared that it goes in the garbage can. But I make sure that everything I write for my letters, at least for my patients, it is in their medical record. So it's not just on a piece of paper. I know we're updating guidelines, but at least there are some resources already on UMDF about, there's an anesthesia guideline, there's an emergency care guideline that I essentially take for my letters for my patients. But, you will ultimately know your disorder more than your doctor who isn't trained in mitochondrial medicine. So, my patients teach me all the time because they end up reading a lot about their gene. But I mean, I think even printing out those letters so that you're informed on at least how you can advocate for your care. And then showing it to your doctors, hey, this is what I found. This is from the United Mitochondrial Disease Foundation. Here's a guideline on what to do if I need to go for an elective surgery, et cetera.
It's distressing to hear the situation that you're going through and that many patients go through. I know that I'm a child neurologist. Most neurologists get trained in a way that they're allowed to take care of adults. The team around me, which includes the nurses and staff that work with me, understand that I actually enjoy taking care of patients over their lifespan. And even though I can't address all their issues as a child neurologist, we do make ourselves available. And when I say we, I don't mean just me, but my staff makes themselves available to physicians in the community that are co-managing the people under my care. I think that probably mitochondrial doctors are the most devoted of all types, and connecting Dr. A to Dr. B is what we like to do. So I'm just going to thank you for your question. Thank you for raising awareness of how terrible a problem this is, and I'm going to pass the mic.
I think one of the things that we talk to our families about who come to NIH to see us is having someone who's kind of an advocate for them, a physician advocate, and the way that the U.S. healthcare system is designed, that's supposed to be, I say supposed to, it's supposed to be your either internist or a pediatrician who actually acts somewhat as a gatekeeper or a person who can help coordinate care. What I would say is that if you feel that that is not the type of support that you are getting from that individual, it may be worthwhile in searching out another provider, because really, they are supposed to, in other words, if you get referred to a neurologist, get referred to a cardiologist, there has to be a single person who kind of, brings all that information together and serves as a gatekeeper for that information. And in the U.S. healthcare system, that is supposed to be an internist or a pediatrician. So having a good relationship with that person, I think, can go a long way.
The kidney doctor that she sees is, I mean, she's doing a very good job of managing this thing, given that she's never seen this kind of case before. So I think she deserves, this particular doctor deserves more kudos than I think Faye is giving her. Just wanted to.
Yeah, the frustration is certainly understandable, though. Without being redundant with what other people have said, one thing I'll mention is that where I work, there is what's called special care clinic for children, and there's an adult special care clinic based in the Children's Hospital, but staffed by internal medicine and medicine pediatrics primary care physicians that are, their job is, they have additional resources and additional time to be able to take care of adults with diseases that in the past were kind of traditionally pediatric or start in the pediatric age range. So I think that the need that you mentioned, which is a very real need, there is some recognition of that, and there is some attempt to create some clinic structures that can address some of the needs that you mentioned.
Okay, we'll take another question from the room, please.
Going back, my daughter has May-Loss syndrome, and we've been on this journey for 10 years. And going back to what she was saying with KSS, I'm in Minnesota, and I can tell those doctors every single thing they need to do for her. I'm just not licensed to write the prescription or anything. How do you get them to listen to you? Because they're not listening. They look at me like I'm crazy. They walk out. They don't want to talk to me anymore. And my daughter's getting more sick now. She's worse off now since November than she was before this. And you argue with the doctors and they just walk out the room. They look at you and they just say, oh, she's got pseudo seizures, or she's got, it's all anxiety ridden. And it's not. You can clearly see it's not. But how do you convince them or get them to actually do what you're saying? It's hard.
Yeah, it can be really challenging. And I know this is a lot harder. What I'm going to recommend, it's a lot harder to do this, especially if you're not able to travel. But, I would encourage people to get a second opinion. And if you're able to travel, if you're able to do something virtually, then you do that. I think there were some recommendations to bring material from the UMDF or, you know, something like that. There's also, the UMDF offers a service that we volunteer for called, the doc is on call, right? So we offer to, take questions from other doctors, right? And so, but again, you know, if the specialist that you're seeing is not listening, then that can be very hard. You can be at an impasse, right? Yeah.
And then that neurologist, I tell them to call her actual neuromuscular specialist. And I'll text him, did they get a hold of you? No, they haven't. So I'll go back to that guy. You're lying. You didn't talk to him because I have his phone number. I'm talking to him right now. And they don't communicate because somebody, you know, is higher up the scale or has oh, I'm a doctor, I can do this. I'm a mom who's looking for answers, and I'm a mama bear because I'm not going to take no for an answer. I don't want to join that club yet. My kid's going to outlive me, but it's just, every July, I'm turning over all this information to the new group of neurologists that are coming in, and I give them all this stuff and say, hey, it's July. You guys are new. This is what you need. My kid comes here. She's not the only one, and you need to know how to treat her. And if you can treat her and save her, you can save somebody else. You know, put down your little badge and your little honor thing and go, and I'll respect you more if you say, no, I don't know the answer, and let me go find the answer, than you looking at me saying, oh, take this little pill. It'll help you. See you later and see you in 90 days. It's stupid.
I'm really sorry you've had that experience. And I'm so sorry. And, you know, one thing I would urge you to do is talk with your primary neurologist and maybe come up with some regular plan for how that person can communicate with the hospital team. Medicine is a team sport, and sometimes the hardest part is getting everybody on the same page together, but
Yeah, I want to mention something, and I don't know if I know in pediatrics, there's a bigger movement to do this more so than the adult world. But especially in academic pediatric hospitals, there's a model to have kind of a complex care type of system where the team knows you. You get the same nurses, you have the same, it may not be the same exact hospitalist, but you're known to the hospitalist team so that you don't have that. It's the new, you know, it's somebody new every single Monday. And it's like this new person and it's a stranger and you're telling the same story every single week. And so if there is the ability to have a complex care team where you feel like, all right, I finally have a home, then you don't have that same feeling that it's, you know, that new person and you have to tell that story over and over again. And I don't know if everybody who's up on stage with me has that type of model at their hospital, but it can alleviate some of this frustration that I'm now hearing in the room. And again, I feel like the adult world may be very behind that model. I don't think that they've embraced it as much as the pediatric world, but I do feel like the pediatric world does this a little bit better than adult world because there's just a lot of complex kids that are out there that need this type of model, right? Yeah.
Won't take her anymore. She's 28. So now we go back to the hospital. They don't have a complex care team at that hospital. They did at Children's, but not at the hospital. So now I'm stuck back in square one again.
Yeah. And then there is another specialty that has arisen, which is this the transition team, right? And I know the Child Neurology Societies worked very hard to try to make this happen. I don't know about other specialties, and I don't know if Dr. Cohen wants to talk about that a little bit more or not. I don't want to put him on the spot, but again, these specialties have recognized, like when you are a pediatric patient and you've grown up with all of the, I don't want to call it a benefit, but like pediatrics and adult medicine, very different, right? And when you turn 18 or 21 or whatever age that is, where you kind of get kicked out of that pediatric system, it is a very rude awakening for the majority of our patients. And so there is this growing need that we've all recognized to have this transition team and to try to really make that transition as smooth as possible. It does not go smoothly no matter what we do, because going to that adult hospital for the first time, I haven't heard of too many instances where that's been a wonderful experience for people. But there have been specialists that train in medicine and pediatrics, and they are transition doctors, and they take care of children that have had complex medical situations, and they are now taking over their care into the internal medicine world. And again, it's to kind of bridge this gap. And they're doing the best they can with this kind of terrible situation we have, where it's not the same care that you get between pediatrics and internal medicine. I'm pediatric trained, so I feel like I'm very biased in saying that. I think if I were internal medicine trained, I might feel differently, but I think pediatricians, I feel like we care more about our patients. It's a very biased thing to say, but I don't know if anyone else wants to chime in about transition of care or complex care models.
That's coming to a fore, I think, in this generation, where we are now getting better and better at extending the lifespan for congenital disorders in all domains. And our adult trained colleagues aren't necessarily used to handling these same complex cases, and it's somewhat new. And I wish we had a single good solution. There are programs at integrated health systems, particularly academic medical centers. Something that you may be able to find, even if you're not in an academic center, is something called an integrated care management program, which will help some with the communication and integration across teams. And if nothing else, can sometimes be helpful in providing another set of hands to coordinate appointments and get physicians to talk to each other when there is a issue that one team needs to resolve before the other can act on it. But I wish we had a better answer, and I'm sorry that we don't.
There is an interesting question that came in that is going to be a little bit of a hot topic, and I don't necessarily want to spend the rest of the time on this, but it's interesting. And this is probably for Dr. McGuire, but I'm going to give you a time limit. if I can. There's a question about long COVID, and is it a secondary mitochondrial disease? Do you think you can answer that in 2 minutes?
Long COVID and secondary mitochondrial?
Yeah, is long COVID a secondary mitochondrial disease?
Oh,
That's
is it
the
a
question.
secondary mitochondrial
Yeah.
disease? Yeah, that's a really great question. Can I answer it in 2 minutes? I think that's a reference to my previous answer, which took a while. Certainly, there have been a number of studies, either basic science studies or even clinical studies, trying to address whether long COVID, actually could be a mitochondrial syndrome. I don't know if the jury is in yet, but there are certain aspects of long COVID, I think, which, are multisystemic. So thinking about whether it actually is secondary mitochondrial, I would call it secondary mitochondrial dysfunction, is a reasonable thought to have. The COVID-19 virus does actually do certain things to the mitochondria, actually to inhibit its function. Doug Wallace had a paper that came out, so Dr. Wallace at Children's Hospital of Philadelphia had a paper that came out just recently, which actually looked at how the virus can actually alter mitochondrial function, or actually inhibit mitochondrial function. Just very quickly, for general information, I'm trying to keep it under 2 minutes. There are a lot of viruses that actually inhibit mitochondrial function. And there are a lot of diseases that do have secondary mitochondrial dysfunction as a component of that. So that area is, and maybe I'll allow my neuroimmunology colleague to answer as well. But certainly there are certainly a lot of diseases characterized by mitochondrial dysfunction that do get worse with viral infections. And there is this very strong area of research going on with regards to what are called host pathogen interactions with regards to mitochondrial dysfunction. So that's not a direct answer, but there is research going on, and people are thinking that long COVID can have a mitochondrial dysfunction component to it. Yes.
Thank you. How about another question from the room?
Hi there. I first of all want to thank everybody. This is our first symposium since COVID. And seeing all the doctors up there, I know all of you guys over the years. And so thank you guys for sticking with us for all these years. I also wanted to say the ER letter for us has been life-saving many times. So please don't think that they go in the trash. Plus, I never let it out of my sight. I always ask for it back. It's a good way. I just had a couple thoughts to help the other people here too. Especially in July, when all the new doc lanes come in. I don't know if anybody else calls them that. That's what we call them. Take use when your doctor comes in, when you're inpatient, and they say, do you have any questions? I always asked, I'm going to use my daughter, said, what did Natalie teach you today? Because it's called practicing medicine. And for us to expect them to have all the answers is going to get everybody frustrated. Nobody's going to be happy with that. But as long as you have a doctor who's willing to learn and you're willing to help educate them, I feel like that saying that just kind of opens the door. Like, I know that we're all in this together. So I guess I don't have a specific question, but I felt like those things might be helpful.
Thank you. Another question in the room?
Hey, thank you so much. I'm going to ask real quick. But we have, I'm going to find it. I'm here. Mast cell activation syndrome. And we've been told by our specialist at UNC that it's often comorbid with things like POTS and mitochondrial disease. And they've said that because mast cells live on the neurons and the cells bother the function, that's what's causing everything to kind of ramp up and become more and more symptomatic. So is there any known theories or hypotheses regarding MCAS and mitochondrial dysfunction? And our kids have POTS, MCAS, and EDS, the kind of trifecta that we're being told is very commonly seen together. But and mito dysfunction and vascular compression too. But we're just interested do you know of any researchers who are also interested in this? Because they found a lot of other people their age online who seem to have this comorbidity constellation as well. So they're finding each other. Are there researchers who are doing research into this subgroup of mito young adults?
So I guess that falls to me. So I am not a mast cell expert by any means. We have seen a few patients through our protocol at NIH who do have mast cell activation syndrome. It's been pretty rare for the patients that we've seen. It's maybe one or two. We do not study it specifically, but we do have colleagues at NIH who actually do address this issue specifically. So as far as theories about how this works, you know, bioenergetics, the ability to generate energy, is a very important aspect of immune function. There isn't much literature out there about mast cells and kind of what they require in terms of, you know, do they burn a lot of glucose? Do they use a lot of oxidative phosphorylation? There's not a lot out there, but it sounds like the questions may be getting more towards, you know, how to manage this basically, and how to help and having this comorbidity with mitochondrial disease. What I would suggest for yourself, as well as people who are in the audience, please contact me. I may not have the answers, but I know people that you may be able to get in touch with and talk with.
Okay, another question from the room?
Hi, I have a question for Dr. McGuire. I've been following you with your researches about immune system, immune deficiency, and the memory. So my kids have inborn error metabolism of fatty acid oxidation disorder, glutaric oxidamine type 2. They've been sick every other month, like during the winter, during the fall. We've been seeing an immunologist at Duke, and the tests always come back like, oh, they're above the marker. They don't need any IVIG antibodies, but they just keep getting sick and sicker. They can't go to school. They skip out of school. Like, is there a recommendations that you can provide?
So sorry, I just had a little bit of difficulty hearing you. You said GA2?
Yes.
Yeah, so that is an interesting disorder, right? Because it's a little bit different than some of the other fatty acid oxidation disorders. Some people think of it closer to a mitochondrial and I'm not saying that fatty acid oxidation disorders are not like mitochondrial disorders, but maybe this one's a little bit closer. And obviously plays a major role in bioenergetics and your ability to, kind of extract energy from your food and be able to your immune system be able to use that. So it sounds like your child is getting very sick with every, flu
Yeah.
season and,
Yeah, he has like multiple flus,
Yeah.
bronchitis, pneumonia.
And did you
sebum.
say he has tried IVIG or no?
No, I've been asking for IVIG, but his immunologist keeps saying that his testing is like a little bit above the marker
Yes.
where he wouldn't need IVIG. So I've been asking and asking, and they finally did a liver biopsy
Yes.
because they have what's it called? Liver fibrosis now.
Yeah.
And then he took some pieces of the liver biopsy to study to hit their immune system. So I haven't gotten a response back, but
Yeah, I mean, so what I can say to that is we do have, and Dr. Goldstein can speak about this as well. We do see individuals with various types of mitochondrial disease who do receive immunoglobulin replacement therapy. And so the ones who receive immunoglobulin replacement therapy, some of them will have, they fall into a number of categories. One of category is they go to an immunologist, they have an immunodeficiency by every definition. Therefore, it's very straightforward, right? So the barrier is usually in insurance. The second category are individuals who get repeated infections and wind up in the hospital, and their disease actually progresses as a result of having those infections, and things get worse and they don't recover those skills and things like that. So we have had individuals, and it seems to be different according to who their provider is and the insurance company that they're working with. But we also have had individuals who have been covered for immunoglobulin replacement therapy for that specific reason. In other words, repeated infection with progression of disease.
yeah, that's exactly what he has. They just repeat.
Yeah, yeah. So it does depend a lot on, and you've talked with an immunologist about this.
Yeah. Oh, we've been seeing immunologist since he was 5. He's now
Yeah.
11, and he's been diagnosed with mild deficiency, but I don't know what mild means. And he's saying like his B cells and T cell doesn't split properly, and he's been following by Duke immunologist. So I don't know what to do at this point because he wouldn't put my kids on IVIG.
So they're saying, sorry, I apologize. I'm just having a little bit of difficulty, and it's me. It's not you. So what you're saying is some of the testing that they've actually done has actually not been indicative of an immunodeficiency, so they're hesitant
Correct.
to put him on it.
Correct. Now, the last testing we've done was from the liver biopsy results, and we were pending on that. And
Well, that won't tell you much about immune function, at least not the immune function that you're specifically concerned about. So, one of the things that you can try discussing with this individual is that, yes, we fully understand that there is a clinical definition of immunodeficiency. However, we are in a situation, right, where my child is getting repeated infections, which is actually deleterious to their health and their medical condition. There are other individuals in the mitochondrial disease community who are receiving immunoglobulin therapy for that indication.
I think his hesitancy was the insurance being paying for that treatment for IVIG. Like if the testing show that he's not at the point where he need IVIG, the insurance won't pay.
So there can be ways to, there are ways to address that, and I'd be more than happy to kind of talk with you offline
Sure.
about that.
Thank you.
Okay, I know we're getting towards the end of the time together. How about if we try to take one more question in the room?
Hi, good afternoon. My son has KSS and he got diagnosed in November. However, every time he got sick and he goes to the hospital, when he comes out, he gets more sick. It's like for now, he can't walk properly. So, okay, let me put it this way. When he goes to the hospital, it's just for a little cold. He goes into the hospital for the cold. He fall in this deep kind of sleep. And he stay like that for weeks. And then he start to deteriorate. He can't walk. He can't see properly. So I just get familiar with all of this. So I would like a little bit more clarity on that because every time he gets sick, he's deteriorating.
I have a question for you just to kind of clarify. So after a few weeks, does he eventually get better and back to where he was, or he stays worse?
That's better, but he can't walk. He walk less, so it's not better. But he's out of the sleepiness, but he got worse.
Okay. So I'm gonna do my best to repeat the question. I may have missed a few of the details, and if anyone can also help fill it in. So what I heard you say is your son has Kearns-Sayre syndrome, and he has to go into the hospital from time to time because he's sick. And he's usually there for a few weeks. And when he comes home, he's not walking and he's much more sleepy. And he's like that for weeks.
No, the sleepiness lasts for a week or two, depends how long he got sick and he's in the hospital. So I'm gonna put it. He doesn't get better. The sleepiness is gone, but he gets worse. So I think it's like he can walk. If he goes, he walk this way straight. When he come out back, he can't walk the way that he usually walk. So I don't know what's going on there.
So I think, again, we can do the same thing that we've done before where we can kind of go down the line. And I just kind of, if it's okay, I'll kind of do the first comments. I've had a tough year with several of my Kearns-Sayre patients. And I was having this discussion with some of my colleagues earlier today. One of my colleagues who's here at the meeting had a child admitted to the hospital with Kearns-Sayre who suddenly became very sleepy, went into the hospital. All his labs looked okay, and nobody really knew what was going on. And he then several days later just kind of woke up and was able to go home. I have kids with Kearns-Sayre that go into the hospital because they're either more sleepy or more dizzy or more, we call it ataxic. They're just not walking as well. And we do all of the tests because one of the things that kids with Kearns-Sayre do is because their kidneys are usually not working well, a lot of them, they can get these very sudden electrolyte disturbances where all of a sudden their calcium is wrong, or their potassium is wrong, or their glucose is off, or their sodium is off. So we check all of that. We might check their EEG just to make sure their EEG is okay. Sometimes they have a pacemaker. We check their pacemaker, or we check their EKG. If they can get head imaging, we check their head imaging. Sometimes I don't find anything wrong and they're just sleeping. I've had kids that come into the hospital, they're sleeping for 5 days. I can't wake them up. I don't know why this is happening. And this has been not just one kid. This is like 3 or 4 or 5 kids. They're not sick. We do all the viral panels. They don't have a fever. I don't know. I don't know what's going on. And so this one little girl had been doing it repetitively. We checked cortisol, we checked all these things. And finally I said, maybe we should just put her on a stimulant. Maybe she just needs to be woken up. And that didn't help her either. So I don't know. I feel like I'm seeing a new symptom in Kernsair. But because she's lying in bed for 5 days or more and not getting physical therapy, when she finally does wake up, she can't walk because she's been deconditioned, right? If you're lying in bed for days, your muscles forget what to do. And so then she usually then has to go to rehabilitation, right? And so we'll put her in inpatient rehab. I don't know if anybody else is seeing this, but a few of my colleagues are seeing this from their Kernsair patients. So I feel like I'm missing something. I'm like, what am I missing with my Kernsair? And if your child is getting sick, right? One thing that we do know, and Dr. McGuire might talk about this, our patients don't handle regular childhood illnesses the same way as children without mitochondrial disease. They can get sicker from a normal cold, right? So I think that is something that I'm texting these kids for. Is it just a normal cold that is just wiping them out? But these kids aren't sick at the time. So anyway, I don't have a good answer, but I'm noticing this is what I'm saying. So yeah.
Every time he goes to the hospital, that specifically he goes for. He fall in this deep sleep that sometimes even soil his skin, that he can't wake up.
Yeah.
And you took him to the hospital like you were explaining. Nobody knows what's wrong with him. They did all the tests and it's the same thing.
Right. They're doing all the blood tests and they're not seeing anything wrong.
Nope.
Yeah.
So
So I'm going to ask the panel, is anyone else seeing this from their Kernsair patients? And what is your checklist for a child with Kernsair that presents with, we'll call it an encephalopathy maybe, right?
Not specifically with Kernsair, but with any mito disease, a high quality EEG with an open mind that these could be seizures. Not everything that is a seizure looks like a seizure on the EEG. A high quality MRI scan with diffusion weighted imaging to make sure there isn't a stroke. Some small strokes actually are pretty big strokes. They may look small, but they can do a lot of damage to the, awake asleep function. I have had one patient that did have a cortisol deficiency that woke up with hydrocortisone. And I think that was it from, thyroid function test. Always check thyroid function. It's a $5 test.
I think Dr. Cohen hit all the high notes. Toxic metabolic workup, and endocrinopathy on the list always for Kernsair. Always thinking about seizures, though maybe a little lower down. But I think one thing also is just your basic, the same medical evaluations that any other child would get for altered mental status. One thing that the families I've cared for have taught me is patients with rare diseases can also have common problems, and they will, and we should never overlook those because somebody already has a rare disease diagnosis.
I forgot one more. High carbon dioxide levels in the bloodstream. I've had 2 patients that were admitted to the hospital in near coma that had a face mask with BiPAP therapy put on them, and they woke right up after weeks of getting sleepier and sleepier.
Any other thoughts?
you said something about stroke. One of the thing too, that the last time he was in the hospital and he was sleeping, his head was just shaking like this. So they didn't do nothing about it. And eventually it stopped. So it's like he's feeling cold and his head is just shaking.
Okay, so we want to thank everybody for your attention. I think the session, if I'm not wrong, was officially over at 5:30. So we went a little bit over, but we hope that this was helpful for everyone. Sorry for any tech issues that came up. We're doctors, not tech experts, so we tried to do what we could do, but we really appreciate your attention. We tried to answer the questions as best we could. It's always interesting and challenging, but we enjoy the challenge, and we did our best with answering the questions that you brought to us. Any remaining questions, Margaret will usually try to send to us, and we do our best to answer the ones that are remaining in the chat. But again, thank you. And we hope that you enjoy the rest of the meeting. Thanks again.